Hello, this is Fernando Gómez Sancha. I'm going to show you a case I did yesterday. This is a man with a relatively bulky prostate. The ultrasound estimation was 90 grams using an abdominal ultrasound. Maybe a little bit smaller, as ultrasound tends to overestimate prostatic sizes. But I'm going to show you the En Bloc technique. It's very beautiful. It's amazingly fast. And I think it's going to change the way we see holmium enucleation of the prostate. So there you can see the sphincter. I tried to mark the mucosa and create this line, what I call a white line, in intimate contact with the sphincter edge. I don't like to go inwards. I don't like to go some millimeters inside, because this is where you have to detach the sphincter right at the edge. So you can see this is an asymmetrical apex. So in one side there is more bulk than in the other side, but I try to stay, as I said, close to the sphincter and delimitate this white line, which is going to serve as a reference for the rest of the procedure. I'm using a holmium 100 watt laser. In this case, I'm not using the new Moses effect, the new Moses system, and the settings are 2 joules and 50 hertz. So it's important to deepen a little bit this white line. See, you can see the sphincter edge, and initially we're going to make the lower part liberation. So I'm going to cut, you see this attachment of the apex to the sphincter in the lower part, trying to get up, let's say, to 3 o'clock, because we will do the liberation of the lower part initially, and I don't want to break the sphincter here. It's quite liberated already. Now I'm going to enter mechanically into the plane at the apex. I found this very fast and very convenient. See, that's how I enter the plane between the adenoma and the surgical capsule. Just with the tip of the scope. I have a special scope from Richard Wolf that allows for this mechanical dissection very, very gently. But this is more or less all of the mechanical dissection I will do. Here I'm just cutting on top of this the verumontanum to join the planes in both sides. And then I will position the fiber at 12 o'clock. Here I'm checking that the liberation of these fibers at the edge is complete, because we don't want to break the sphincter's mucosa. So now for the remainder of the procedure, I'm going to keep my fiber at 12 o'clock, and I will not rotate it. I think it's important to make this operation simple, and having to rotate the fiber, having to rotate usually confuses more than it helps, in my opinion. So I like to keep it at 12 and work with the camera fixed at 12 and the fiber fixed at 12. Okay, so I like to do posterior dissection. Initially, take it a little bit into the prostate, in the direction of the bladder neck, without taking it too far. Just, let's say, dissect what is possible to dissect. In this case, the plane is not very beautiful, but there you go. I think this saves a lot of time, makes separation much faster, and you have to be always aware that there might be nodular growths that are growing inside the capsule. So always looking for the good plane, but also keeping an eye on the possibility of nodules that grow, pushing the capsule and compressing it. And you see now, when we go back, the apex has been liberated until 3 and 9. So all the lower part of the apex has been liberated. Okay, and this is the trick. I have to go now and cut into the prostate, following this white line, keeping the fiber horizontal, especially at the 12 o'clock area, so from 11 to 1. And then once you have, let's say, detached the prostatic apex from the sphincter by doing this cut, then you can go and look for the proper plane. Many people think if you cut into the prostate, you're going to miss the plane. Okay, no, the idea is this cut will, let's say, liberate the sphincter from the apex. And then afterwards, this is the, let's say, 12 o'clock position. This is the other side. Here I can see, you see the white line. What I'm doing is cutting into the prostate first, a little bit, just 3-4 millimeters in depth. You can see now that the prostate detaches from the sphincter a little bit, and then you see this would be a wrong plane, but I'm not concerned about this now because I will go to look for the good plane. You see, once I have cut 4 millimeters into the prostate, 5 millimeters into the prostate, following the white line, keeping the fiber horizontal at the 12 o'clock area, what I have done is I have detached the sphincter from the apex. Here still, you see, you have to follow this curve that we marked initially. Bring it up slowly. Don't hesitate to cut a little bit into the adenoma. You see, that's the mucosal edge at 12 o'clock. And then this allows you to go again into the right plane and look for the right plane to go all the way anterior. This is what I call the early apical liberation, which means that we're going to liberate the apex right at the beginning of the procedure. And why is that important? I think when you liberate the apex completely at the beginning of the procedure, you stop worrying about the sphincter. And also, I think that this limits distension and traction of the sphincter. Here, you see the attack to the apical liberation has to go from the lower part, coming up, and then see if you can join from both sides in the midline at 12 o'clock. Okay, the important thing is to know that once you deepen this white line, you are, let's say, working a little bit far away from the sphincter now, and you can see that we will be able to preserve the whole mucosal lining of the sphincter, which I think it's very important to preserve continence. So here you can see that now we progress a little bit, following the right plane, trying to come up at 12 o'clock, and let's say join the dissection on both sides. This is the trickiest part of the operation. This is the, let's say, the part of the operation that can take longer, maybe 10 minutes or so. And then once the sphincter is totally liberated, the rest of the procedure is a piece of cake. It's very easy. We have many advantages of this approach. One is that, as you can see, we are only irrigating a very small space. We are not irrigating into the bladder. You see, we are developing a space between capsule and adenoma. Here, I think I'm connecting now, let's say, both planes at 12 o'clock. There we go. So now you have to follow this plane. Try to go as much up as you can so you don't leave anterior tissue. But I would say that the first consideration here is respecting the sphincter. If there is some anterior tissue attached to the sphincter, at the end of the procedure, you can always review it and take it out. If you were not, let's say, if you left a little bit of tissue anteriorly attached to the sphincter. As I was saying, this space is irrigated very efficiently because it's very small. And if there is bleeding, the bleeding is washed out. This blood doesn't go to the bladder and stays there, as it happens when you do a 3-lobe technique or you do incisions in the prostate in a classical way. So now you see that the procedure is going to be a piece of cake and extremely fast, because we are dissecting this line of attack. This line of attack, look at the sphincter, how beautiful. The whole mucosa has been preserved. I'll show it to you later as well. But as you can see now, the idea is that we can follow all around. We have a line of attack that it's going around, and you just have to follow this line. Okay, instead of going very deep in a very small area, what I try to do is to follow this wide line that orients you very well and tells you where you are. You see the fiber is always kept at 12 o'clock. And you will see that this prostate has some nodular growth in the lower part. We will see how to do. Okay, so initially the plane has to open because we are dissecting a spherical or nearly spherical adenoma. So what I do is at the beginning of the procedure, my targeting of the line, you see it's a little bit external. So as I am dissecting the initial part, I need to open up a little bit. So my fiber is going to dissect just firing straight at the attack line, you see, this way. But then, of course, when we are more than the equator, when we are progressing, we need to close a little bit. We need to get close to the adenoma. So my fiber is going to fire, let's say, more close to the adenoma. It's very simple. There are two places to fire. At the beginning of the procedure, you will fire straight at the attack line. And as we have to, let's say, get closer to the adenoma to follow the contour of the prostate, and here you can see this is the bladder neck. You can tell very easily because the fibers of the bladder neck initially are round, as you can see, but then we find these vertical fibers that unequivocally tell you that you're going to enter the bladder. So that's the middle lobe we saw before. It's cutting the mucosa anteriorly. Typically, I would dissect the bladder neck, let's say going down and trying to reach 6 o'clock. You'll see in this case, things turned out a little bit differently. But I think it illustrates very well how fast this dissection can be and how easy the good visibility we have because the irrigation is amazing, and how easy it is also to follow the line of attack. Okay, here now we are, let's say, closing in the posterior aspect. You see, initially we descended, we went to the equator of the adenoma, and then we have to ascend. And here you can see that this is the lateral aspect, and now this is the posterior, lateral again, trying to liberate this part. But you can see here how flimsy the capsule can get when you have a nodule that pushes the capsule and thins it. So carefully, here we are in danger of, let's say, perforating, but here you have to stay very close to the adenoma, very close. You see my fiber and the energy, let's say it's mainly hitting the adenoma, but the plane will dissect and there will be some coagulation effect on the prostatic capsule. So there we are, just following this line. As I said, usually I would continue cutting the bladder neck from anterior to posterior, and then I would take both incisions in both sides, let's say closer and closer to the midline until I can liberate the adenoma. But here you'll see that we're going to find there's a very nice middle lobe pocket that dissects very easily and we're going to enter the bladder from the posterior aspect. Yeah? This is one of these nodules, you see. They grow and they thin the capsule, but you need to take them out. And I think it's safer, it's very safe if you keep close. You see, I keep close to the tissue now. I don't work now firing straight at the line of attack, but a little bit closer to the adenoma. And this will dissect this plane even when we are, let's say, climbing up the retrotrigonal space sometimes. There we go. So you can see that we entered this pocket, this middle lobe pocket, very nicely, very beautiful. And at some moment I thought, okay, this is the mucosa of the bladder. Let's go inside the bladder. This is not so common, but there we are. It was very easy to enter the bladder, to cut the mucosa, and we had, let's say, dissected the anterior part of the bladder neck, and now the posterior, and now we have to connect in both sides. So this would be one of the sides. You see now the prostate is free, just hanging from two attachments in both sides. Here I was trying to go up and see, but you see the prostate had lifted a little bit. It was not so easy to access, so it went to the other side, anteriorly, trying to see, you see, how to connect both aspects. So very easy, very fast, very easy orientation. And I think this is going to become the standard way of doing HoLEP, because it is so fast, and also you are so relaxed when you are, let's say, dissecting the tissue and knowing that the sphincter is perfectly healthy. We've seen very, very low rates of incontinence, and also being able to do these prostates in 30, 40, 25 minutes, 1 hour for the largest cases, 1 hour and 15 minutes. You know, it really changes everything. The other thing that changes everything is the fast morcellation provided by the Richard Wolf Piranha system. I think this has changed our lives. But here you see this is the final detachment, and I'm going to show you how the sphincter looks at the end of the procedure, which I think it's a beauty. You can see that it's not even 20 minutes, I think, when the enucleation finishes. I'm not going to show you the morcellation, but there you go. That's the sphincter. Look at it. Wonderful preservation all around. I hope you liked it.